Hi everyone, welcome back. This is the seventh unit of our time together in the course, and as you'll already note, this week you will be reading about inequality, social inequality, and economic inequality, and some important information about the effects of inequality, including on several outcome measures, but one in particular that I want to draw your attention to in the last reading that I assigned is the impact of inequality on health and healthcare outcomes. Things like life expectancy, infant mortality, and just the overall health of people in the United States. So when we think about inequality in health, there is, as a concrete example of the way that social organization and society can have an impact on individuals' lives and then on groups of individual lives, it creates for us a really nice concrete example of how to think about the impacts or the effects of inequality, whether we're talking about social inequality in terms of social status or economic inequality, which of course can be relevant to social status as well, with people who have more money as occupying a higher social status and people who have less having a lower social status, and then just the material consequences of what having more or less can mean for something like health. So I want to begin with an overarching point, and then I'm going to tell a story that I hope, it's a real life story of something that happened that I hope will really bring home the idea that I want to get across to you about the relationship between inequality and health. And of course, there are many social phenomena, many phenomena to study under this general umbrella, and we're going to talk about a few of them. So a key point for our lecture today, which was made by a sociologist of health and medicine, Dr. Epstein, is that the ways the ways that societies are organized plays a critical role in determining the kinds and distributions of illnesses that people suffer, as well as determining who is more likely to be affected by those illnesses and how seriously. So, just to simplify this, social organization, or how we've set up our society in terms of who has access, who has opportunity, how we treat those who are of a different race, how men and women and transgender people occupy different status in society, and then the larger systems in which those social divisions play out really have tangible consequences on whether people are more likely to get an illness, and then whether or not they're able to get treated if they do happen to get an illness, and affect things like life expectancy and overall health status. So when thinking about this, about this broad topic, I want to remind you of a key term that you learned in the Intro to Sociology class, and that is the sociological imagination. And so we can ask, how is the sociological imagination helpful for thinking about health disparities, that is, differences in health outcomes, as a function of inequality, whether we're talking about social or economic inequality? So for me, the sociological imagination is a way of thinking. It's a way of thinking about that which may not be visible to us in our day-to-day lives, but is nevertheless real. So what do I mean by that? Well, there are larger trends and patterns in society that we as individuals may not have access to in our immediate lives, but that doesn't make them any less true. So for example, if we use sociological methods and statistics, we can see that there are group-level differences in things like health outcomes, and that those group-level differences are a product of the way that that society is organized. And we may not, in our own lives, see that. So, for example, if we happen to have a job, make a pretty good living, we may not experience in our day-to-day lives how, at a larger group level, because people who are similar in many respects tend to group together. They live in relatively homogeneous communities. And of course, that doesn't mean you aren't aware at all, but it takes a bit of sociological imagination to see that based on one's social position in society, one may not experience some of the challenges that another person who occupies a different social status in society faces. And so the sociological imagination allows us to think about those group level differences that may not, again, be immediately visible in our day-to-day lives. Now, for sure, many of us occupy different social categories in our lives, and we could take something like social class, for example, and we do experience and have a sense that our opportunities, our opportunities and availability of something like healthcare is different from other people. And so I'm not saying that you have to have this sociological imagination to understand what I'm talking about. Indeed, many people who are poor face challenges in their daily lives around something like accessing healthcare or paying for their medical bills. And so that's experienced in a very real way. And yet, any given individual still can't know all of the different patterns because they may not experience all of those different groupings that one might be a part of. Another example might be if you are of a minority racial status, you may have encountered or may be more likely to encounter discrimination when it comes to accessing healthcare or of getting the kinds of medications or the kinds of medical care that you need. Now, that's not necessarily true for everyone, but certainly we are aware that, for example, Black Americans are more likely to face, who experience pain, may be more likely to experience skepticism from a medical care provider that they really are experiencing pain and need something for that pain because of a larger social stereotype about Black people who may be looked at as if their pain is just a way to get a painkiller because they're an addict, for example. A very pernicious stereotype that I'm not, of course, saying all medical healthcare providers hold. In fact, it's probably relatively few, but we know of many examples of people who have experienced just that kind of discrimination. And the group level trends tend to suggest that people who are African American are more likely to experience racial discrimination when it comes to accessing healthcare. In addition, another example might be the long history of skepticism toward the medical health community among African American people because of the real abuses of power in experimentation around using Black people for medical experimentation to track, for example, the progression of different diseases without the knowledge of those participating in those studies, the most famous of which is the Tuskegee experiment, which I encourage you to look up if you're not aware of it. But that is by no means the only example. And so built into certain communities may be a sense that they are relatively devalued in society among different institutions which are there to care for people and to provide treatment. And it may have an unfortunate outcome of making certain people less likely to seek out medical care when they need it, aside from any economic hardships that they may experience as well. So those are just a couple of initial examples of how the sociological imagination is really important to us to really think about what's beyond our immediate experience, our immediate personal experience, in order to get at some of these larger group level trends. And so I'm going to talk about some of those trends and how statistics and how tracking patterns can be helpful to reveal disparities in health outcomes as a function of social inequality. But first, I want to tell you a little story that I think will also bring this home. The story that I want to share with you happened. It's a real event that happened in 1995, and it happened in the city of Chicago. there was a heat wave. It was, at the time, the most deadly heat wave that this country, the United States, had ever experienced. Temperatures soared to over 100 degrees Fahrenheit, and this continued, meaning the highs continued for about a week straight, with nighttime highs staying in the 80s. At the end of this heat wave, over 700 people died, and most of the people who died were elderly, and they were more likely to be poor, and they were more likely to be white or African American, with African American men most disproportionately affected than any other single group. And so this period of intense heat resulted in about 700 more deaths than what was expected for a heat wave of this intensity. So it was quite dramatic to have so many people found dead from this heat wave. More importantly, these people who died all had something in common, or most of them had something in common. And aside from the fact that they were elderly and not so well off financially, and that was that they were found dead alone in their homes and had been there for a couple of days, suggesting, that they lived alone. And when sociologists and epidemiologists went back to study what those who died had in common, they found out that yes, they lived alone, but lots of people live alone in Chicago, and most of the people who live alone in Chicago didn't die during this heat wave. And so the question was, is it just the fact that these folks lived alone, or was there something else going on here? Well, it turns out that the other thing that was shared is that the people who died were less likely than those who survived to have a social network that lived close to them. So those with even minimal social contact were significantly less likely to have died during this heat wave, all things equal, even if they lived alone. So in other words, those who didn't have a close social network or someone to care for them living in close proximity, which is not the same as saying that there wasn't anyone in their lives that cared for them. It's just that the people who cared for them didn't live very close to them. And so a sociologist by the name of Eric Kleinenberg wrote a book after doing some extensive research on this heat wave and trying to understand why these people had died, including this point about social isolation. But his question was a bit broader than that. It was like, well, okay, social isolation, these people were alone, but it didn't quite answer the question of why. So some of the questions that he asked in this book were, why did so many die during this heat wave? How do we explain their social isolation? So why are some people socially isolated and others not? And then how does that social isolation increase the risk of dying during something like a heat wave? What social and psychological processes organize the experience of aging alone? So why is it that so many elderly people are living in increasing isolation, which tends to be what he found over time? Increasing numbers and percentages of elderly people are not only living alone, but having fewer people that they have a kind of regular contact with, physical contact with. So, and how can we understand the lives and deaths of those who are totally isolated? And what does that have to do with broader social organization and social institutions, which is part of the focus of our class? And I want to read a passage from Dr. Kleinenberg's book, and I will post this chapter to the website. And so first I want to make clear that I am quoting directly from one of the chapters called The Social Production of Disease and Illness, and in order to convey a story of one of the people in his study that he focused on, an elderly woman who didn't die during this heat wave, but who nearly did, and how her personal story isolates this, or I'm sorry, reveals or reflects this larger point about how social organization and trends over time in American society can help to explain how elderly people are increasingly vulnerable to environmental effects of something like a heat wave. So this person's name is Pauline for the purposes of this study, and Pauline was an 85-year-old woman during this heat wave in 1995. And she lived in downtown Chicago, where so many people like her died during this heat wave. And Pauline says to Dr. Kleinenberg during an interview that she really closely came to death. She was very close to dying during this heat wave. She had one air conditioner in her apartment, which gets especially hot during the summer, Dr. Kleinenberg writes, because it is on the third floor of her building. But the machine is, quote, old and it doesn't work too well, end quote, which left her place uncomfortably, if not dangerously warm, during this heat wave. A friend told her that it was important for her to go outside if she was too hot, indoors, so she would wake up very early, because she said it's safer then, and on what would become the hottest day of the heat wave, she did get up very early and walked to buy cherries at a local store. And she did this because she did not have air conditioning in her building, and the local store did have air conditioning. Quote, I was so exhausted by the time I got down the stairs that I wanted to go straight back up again, she recounted, but instead I walked to the corner and took a bus a few blocks to the store. When I got there, I could barely move. I had to lean on a shopping cart to keep myself up, end quote. But the cool air revived her, and she got a bag of cherries and returned home on the bus. Quote, climbing the stairs was almost impossible, she remembered. I was hot and sweaty and so tired. Pauline called a friend as soon as she made it up to her place, and as they spoke she began to feel her hands going numb and swelling, a sensation that quickly extended into other parts of her body, alarming her that something was wrong. Quote, I asked my friend to stay on the line, but I put the phone down and lied down, end quote. Several minutes later, her friend still got on the line, but the receiver was on the floor. Pauline got up, soaked her head in water, directed a fan toward her bed, lay down, and placed a number of wet towels on her body and face. Remembering that she had left her friend waiting, Pauline got up, picked up the phone to report that she was feeling better, and thanked her buddy for waiting before she hung up. Finally, she lay down again to cool off, and she rested in earnest. Before long, she had fully recovered. Now, she said, ending her story, quote, I have a special way to beat the heat. You're going to laugh, but I like to go on a Caribbean cruise, end quote, which she does alone, and which she does nearly everything as she does nearly everything else, without leaving her home. So that is, she goes on a Caribbean cruise, and this is what she meant by a Caribbean cruise. I get several washcloths and dip them in cold water. I then place them over my eyes so that I can't see. I lie down and I set the fan directly on me. The wet towels and the wind from the fan give a cool breeze, and I imagine myself on a cruise around the islands. I do this whenever it's hot, and you'd be surprised at how nice it is. My friends know about my cruises too. So when they call me on hot days, they all say, Hi, Pauline, how was your trip? We laugh about it, but it keeps me alive. So Pauline's story is not that dissimilar to many in her socioeconomic status and her age group. She is relatively isolated. In this case, her contact with the outside world is relatively limited. Short bus rides to get to the store. She doesn't have air conditioning. She does have a friend, so she's not completely isolated in the absolute sense, but this friend was not available to come in and check in on her. And although she did have someone to call, many of the people who died were in a similar position. It wasn't so much, again, that they were completely alone, it's that they were socially isolated in the sense that they didn't have someone to reach out to, and they were relatively kept inside of their homes for a number of different reasons. So Dr. Kleinenberg, the sociologist, wanted to know what accounts for the social isolation of people like Pauline, and indeed like those who died as a result of the heat wave. In other words, what were the most important social factors and conditions that contributed to isolation and to death? Well, the first was an aging population of relatively poor racial minorities in an urban context. That described most of the 700 people. Not all of them were racial minorities. Many of them were older, poor white people as well, but racial minorities were disproportionately affected by the heat wave. Another factor was fear of crime. So many of the elderly people who died and those who were like them, who lived and talked about why they don't leave their homes, there was a common theme among them, and that was fear of going out into the world as an elderly person in a place where crime rates had increased over the decades in an urban centers of Chicago, and feeling quite vulnerable that they would be targeted because they were elderly, sort of an easy target for being mugged and hurt in the process of being mugged. And so it's true that there were rising crime rates in these areas, but also there was a kind of media effect as well, in which the media tended to trump up certain narratives around certain areas being more likely to be crime-ridden than others that tracked along basically racial and economic status lines. So while it is true that there were increasing reports of crime in the areas where people lived in isolation, people's perception of crime tended to be greater than what was actually the case. And that might be because there's a lot of attention on certain kinds of crimes in the American media than on other forms of crimes, and those narratives really have an impact on people's perception. And so that might have made it even more likely that someone stayed inside in their hot homes if they lacked air conditioning and been subject to the extreme heat. Another factor that Kleinenberg found was the degradation of public spaces, and this is a result of a larger social process, which is the lack or loss of public funding for street improvement projects, for community housing projects, for the kinds of social support that many people who are on a fixed income, including elderly people, rely in order to feel safe in their environments. So it actually did allow this loss of funding, of public funding, and loss of public space and care for public space, allowed certain areas to become spaces for crime and kept older people from venturing out. A fourth factor was the loss of social safety net programs. For example, not too long before this heat wave, there was a cut to home energy subsidies. So many people who maybe a decade prior did have help paying for air conditioning to cool their homes because of public assistance programs lost that ability. And again, because they didn't go when their temperatures rose in their apartments and they were fearful to go out and didn't have someone to come accompany them, they stayed inside of these sort of baking apartments in sometimes high rises. And then a very important factor that one has to see as a broader pattern over time was spatial distance from family. So there's this phenomenon of suburbanization that's occurred over many decades, and this was no exception in the 1980s and 90s leading up to this heat wave. And this is a phenomenon whereby younger families tended to be able to, younger families that had the economic resources to move away from urban centers did so in order, in part, to get away from the declining urban conditions that were in part a product of the loss of things like public funding. And so this spatial distance meant that close family members, even though an elderly person might have family and talk to them on the phone, they weren't close enough to come just swing by and check in on their family member. Or the family member might have said, "Oh, I'm okay," when they were on the phone, and not realizing in what danger that they were in. But if families had been closer by, they might have been able to stop by just to check in on mom or dad and see, or grandma and grandpa, to see how they were doing, and realize that the conditions were not conducive to staying in the apartment. So a key point that I want you to take away from this very sad story is that, in many of the death certificates of when the people were found in their apartments and then a cause of death was declared, that cause of death was often something like dehydration or heat exhaustion or heat-related dehydration, which led to dangerous conditions for people if they had heart conditions and other things like that. But we can separate out what the proximate cause of death was, maybe heat exhaustion or dehydration, from the broader fundamental cause, or the social conditions in which heat was able to kill some people but not other people. So again, it wasn't just the heat that caused death. Heat was the proximate cause, but there were more important fundamental social causes at play that allowed heat to take some lives, but not others, depending on things like material, economic resources, and how those resources are distributed differently to different groups within the population. That's how sociology is quite important, to take this broader lens to see not only the physiological and biological conditions of people's lives, but understand how biological and physiological conditions can be the product of fundamental social arrangements in our society. So coming back to that key point that I made earlier, the way societies are organized plays a critical role in determining the kinds and distributions of illnesses, or the impacts of something like, say, a heat wave, that from which people suffer, as well as determining who is more likely, or what groups of people, we might say, are more likely to be affected than others, and how seriously. I want to just say a couple things about what I mean by social organization. Social organization refers not just to healthcare infrastructure, but even larger arrangements like a country's political, legal, and economic arrangements. I hope that's clear. And no matter what country we're talking about, though this class focuses on American society, or I'm going to give you a couple of examples not from the United States, these institutional level arrangements can contribute to health disparities on a group or individual level, depending on things like age, class, race, gender, sexuality, and so on. It's a basic sociological point, but it's extremely important. So I want to give you a couple of other examples of how social organization can affect something like health outcomes, like and even death. So well, this slide takes us back to the point that I was making before, which is proximate cause versus what's called a fundamental social cause. Again, a proximate cause being, say, maybe what's listed on a death certificate, the most immediate thing, say a heart attack. But that doesn't really tell us what the fundamental social cause is of why some people are more likely to have a heart attack than others, why some people are more likely to die during a heat wave than others. For that, we have to broaden our lens sociologically and think about how society is organized socially, that in ways that lead to a greater likelihood of somebody being affected by a disease or by an environmental disaster. So if we're thinking about something like environment or environmental issues, we can look at air pollution and social organization and health outcomes. So in 2013, 5, 6, 7 years ago, which is the most recent data I have, air pollution contributed to the deaths of 5.5 million people across the world. Not talking about in the United States alone, but across the world. First, people experience air pollution to different degrees depending on where they live. According to one study, the majority of deaths from air pollution occur in China and India, with over 1 million premature deaths each year as a result of air pollution. Of course, saying 1 million premature deaths per year also reflects the populations of these high population countries. Both China and India have large populations, so you might expect greater numbers of people to die there as a result of air pollution than in other countries. But it appears to be compounded by the way that these societies are organized at a societal and structural level. So, for example, in China, there has been rapid industrialization, but this industrialization has largely occurred without the kinds of environmental regulations and controls that we have in the United States. That isn't to say there aren't any, but we have much more stringent requirements for industry to keep our air relatively clean, though of course there's still a lot of pollution, but relative to China, those protections or regulations protect our air and they protect our water, and they're actually the result of social organizing to demand more stringent regulations in the 1960s and 70s, when air pollution was really on the rise in the United States and causing many people to become sick and ill with smog in their local communities. And it was really becoming undeniable that the air was becoming more and more polluted and that people were getting sick. And thanks in part to environmental activists and just everyday people who didn't want their children to grow up without any standards to keep air pure, people began to make demands on the government. And the government, under Richard Nixon, in fact, established the Environmental Protection Agency and supported a number of environmentally conscious laws like the Clean Water Act and regulations to prevent air pollution. But in China, the extent of these regulatory reforms has not kept pace, we could say, with the rapid rise of industrialization. And so you have areas of the country with larger levels of air pollution, and as a result, a larger proportion of people getting air-related illnesses, pollution-related illnesses. Now, it's very tempting for people in the United States to point their fingers at China and say, that they are bad actors on the world stage. And of course, there's a little bit of a hypocrisy there, because China also is responding to global demand for cheap goods and services, or cheap material goods from places like the United States. And so that isn't a reason not to advocate for regulations, but it is important to keep that in mind when we point fingers at another country and say, you're contributing all of this pollution, at the same time that we demand cheap electronics, cheap goods and services, and continue to buy them, knowing that they're produced in a place that doesn't have environmental regulations. So while we can advocate for those kinds of changes, we should also be self-reflexive about the way that we present those kinds of arguments and about our own consumptive practices. Another example that I'm going to talk about both here and then later in the lecture is that life expectancy is a function of social organization. And in a very dramatic example, we see this if we look at the difference between the countries of North and South Korea. So the difference in life expectancy between North Korea and South Korea is a dramatic example of how social organization can make a difference. So in North Korea, the average lifespan is 70 years. In South Korea, which is just south, literally across a line, a border, it is 82 years. So how does social organization relate to life expectancy? Well, we can, this is not a complete analysis, but North Korea is a dictatorship. It is largely isolated from the rest of the world. And a large portion of the population does not have regular access to adequate food or health care, despite claims by the government that it does. Of course, we don't know for sure exactly what's going on within the borders of North Korea because it is a very secretive country. They're not exactly sharing statistics, and if they are, we don't know to what extent they can be independently verified by experts. So when they say that they have adequate food and health care, we have a number of reasons to believe that that's not the case. And so malnutrition and communicable diseases, from the information that we do have, accounts for 64% of deaths in North Korea, but only 8% of deaths in South Korea. Again, malnutrition and communicable diseases account for 64% of deaths in North Korea, but only 8% in South Korea. Again, if you know anything about South Korea, you know that it is a democracy. It has rapidly increased its economic standing in the world. It used to be, not that long ago, a few decades ago, one of the poorest countries in the world, and it underwent a rapid economic development to become one of the wealthiest countries, in fact, in the world over a matter of a few decades. And as a result of this newfound wealth at the country level, South Korea began to provide universal health care to all of its to all of its citizens beginning in 1977. And that universal health care help to cut down on preventable illnesses, therefore extending life expectancy. So a central point here is that health inequalities around the world reflect social inequalities, the North and South Korea divide, making that pretty clear. And just a list of some of the major sources of health inequality include things like limited access to medications, to health professionals, and to medical technology. Perhaps because they don't exist within a society, or that they do, but they're too expensive for some people, particularly in the United States, where we don't have a universal healthcare system, and where your ability to pay for medical care determines whether you get it or not. In many cases, we do have, of course, health care systems that allow poor people and elderly people to access care, but many people fall through the cracks in those systems, aren't aware of how to get that access, and so on. And if they need more expensive kinds of medical procedures, they may not be able to afford it. And in fact, even middle income people may be at more risk because they maybe don't have health care. Or they do, but they have high premiums and can't pay for the health care that may be available to them. Something like limited access to basic needs, such as food, clean water, shelter, and education. So, for example, nearly 800 million people don't have regular access to clean drinking water, and 2.5 billion people around the world, don't have adequate sanitation, which leaves them exposed to a number of illnesses and diseases. The source for that is the United Nations. Something like exposure to life stress reflects social inequalities. So if, for example, if you are in a poor country and you are poor, you are more likely to work in a place that may not have very safe working conditions, like a factory. Or there may not be regulations on the number of hours you work, as there is in the United States with our 8-hour workday, a number of regulations that were put in place during the labor movement in the early or late 1920th and early 20th century, and how much one has to work in order to afford basic needs. And there are also political impediments to a healthy life. We can consider whether political arrangements work for the benefit of people's access to health care or against it. Okay, I want to move on to models to explain health disparities, because it's a very important point of debate when people talk about who is more likely to get an illness or die early, and how we explain health disparities at the group level. So we have two models, two main models. One is the individual lifestyle risk model, which is the idea that it's really people's behavior at the individual level that accounts for their illness. So what and how much they eat, whether they exercise, whether they smoke or drink, whether they drive or walk, and that these are the behaviors that that someone can make choices to you could choose to walk or drive, for example, is an argument. You can choose what you eat, and to some extent, yes, you can, but so to some extent that's constrained by larger social processes. But this individual lifestyle risk is the idea that it's your individual behavior that determines your health outcome, or why someone develops an illness and why someone doesn't. But the limitation to this model is it doesn't take into account those larger social conditions that I just discussed. For example, what might appear to be an individual lifestyle choice or behavior might actually be shaped in very important ways by social conditions. So, for example, by what is available to some people and not to others. So you may be familiar with what's called a food desert. This is the phenomenon whereby people who are poor, who live in poor areas of, say, cities or of the country, don't have as great of access to healthy food options, or what we would consider to be nutritious food options, compared to people who have access to relatively more resources, whose communities have more grocery stores and fewer fast food places. And so the availability of certain kinds of foods is already constrained to some degree by how food is distributed at a larger level. So if, for example, if there's nothing but fast food restaurants within a 2-mile radius of you, and you have problems making ends meet, and you don't have extra money to spend to drive 20 miles to a grocery store, or 10 miles to a grocery store. And then if you do that, and you get to the grocery store, and those organic fruits and vegetables are more expensive than it would cost to just buy some frozen food, which may have lots of preservatives and be high in salt and fat and calories and this kind of thing. Well, you're just trying to feed your family with the budget that you have. And so, yeah, someone can say to you, well, why didn't you cook up that, gourmet, organic food with lots of vegetables and salmon, which costs $25 a pound? But your response is, I can't afford it. I'm working 3 jobs. I can barely make ends meet. And so I just have enough money to feed my family so that they're not hungry tonight. And that food that I'm able to feed them, because it's relatively inexpensive, is less likely to be particularly nutritious. And over a person's lifespan, having access to only those kinds of foods may help to explain why poor people have poor health outcomes. And it's not so simple as to say, well, you could have just eaten healthier. The same with something even like smoking. Smoking is certainly, we can choose or not choose to begin smoking, but we see trends whereby poorer people who actually have less disposable income tend to smoke at higher rates than people who are well off. And this may be a product of things, of the kind of perpetuation of smoking within a particular socioeconomic status for other reasons. It may reflect the levels of stress in a poor person's life, and smoking as a way to relieve stress, and then the addictive qualities of smoking and how hard it is to quit, and whether you have enough money to pay for a program or a prescription that helps you to quit smoking. So maybe you made a bad choice, or a quote-unquote bad choice. I don't particularly want to moralize people's choice to smoke or not. If you're a smoker, I don't care. But there, of course, is good evidence that smoking has negative consequences on health outcomes. And I'm suggesting it's not so easy as just to say, oh, well, that person chose to smoke, and therefore they have poor health outcomes. Well, we have to ask, well, why? Why is it the case that poor people, even though smoking is kind of an expensive habit, tend to smoke more often. Maybe it's because they have more stressful lives and smoking helps to relieve that stress. And then once they're hooked, they can't afford to stop because they don't have access to medical care in the same way. They can't afford that prescription. They can't afford that cognitive behavioral training that helped the wealthier person get off of smoking. So this is one model, and it has some explanatory power, but it's not as it doesn't cover the broader sociological context in which people that account for people's health disparities or disparities between groups of people. And so something like fundamental social causes is a way of capturing that broader social context. So it just refers to the broader conditions in which individual actions take place. Fundamental social causes can, in fact, influence or even determine a range of health-related choices and actions that may be available to some and not available to others. Social conditions might in part determine whether an individual behavior leads one person or group to develop a disease or to die early, while another person or group does not. So I want to show you the top 10, the top 11 global health risks as of 2004. The World Health Organization listed them in 2009. And, this is not the most recent data that could be available, but using this slide because the overall patterns are about the same. So in this list of 11 factors that account for health risks around the globe, we see that lack of nutrition was the number one global health risk if we combine all the various nutritional deficiencies. And that this poses a risk to people's, their health and how long they live. And we can immediately see, if we stop and think about it, why saying lack of nutrition is explained by the individual, if I go back to that other slide, the individual lifestyle risk model. Well, obviously, people in two different countries may have different kinds of foods available to them that depend on many other factors, such as how poor that country is. And of course, you don't choose what country you're born into. Also, how that food is produced, imports, exports, manufacturing processes. And again, we could ask, what if someone lives in a wealthy country and they just eat ho-hos and big gulps all the time? Isn't that an individual lifestyle risk? And isn't that person to blame if they develop diabetes? Well, it is a lifestyle risk, and there is some degree of choice involved in what we eat. But again, if we just stopped there, we would miss very important sociological factors in the ways that what we have access to, what foods we even were exposed to as children because of our socioeconomic status, that for example, became comfort foods to us to deal with the stressors that we have in our life, and how difficult it is then to break out of those certain patterns whereby certain foods become staples in some people's diets and not in other people's diets, simply because some people were exposed to certain kinds of foods that other people were not. Again, if you think about organic food tends to be more expensive than non-organic food. It's more expensive to produce, often because it reflects greater inputs in order to grow organic food. So, non-organic food has been economized through the use of fossil fuel fertilizer. Organic food is actually more expensive to produce and often requires larger amounts of land to produce, and it's more difficult to battle pests if you're not using pesticides and so on. And often the higher cost of organic food reflects those inputs and reflects the economies of scale, whereby non-organic foods have reached a sort of economy of scale, may or may not be more or less nutritious. It depends. I mean, you may be more exposed for certain non-organic foods to pesticides, and in the long run, you may be, better off paying more for that organic food, that organic celery that doesn't have pesticides concentrated in it. But if you're a poor person and you're just looking at the organic food and the non-organic food and which one is cheaper, and you only have a certain amount of money to last you through the week, you're just going to buy the non-organic food, and maybe you don't ask questions about the pesticides that are used, or you just can't afford to ask those questions, or you don't want to think about it, and those kinds of things. Again, these larger sociological factors. All right, so you might be wondering, well, what are some of the major indices or measures or outcome measures that we use to look at health disparities? And these are relatively crude measures, but they give us a nice way to begin to see how social organization affects things like health outcomes. And so at the global level, and this is then important when we think about within a society, looking at different demographic groups, different racial groups, different genders, and so on. So three major indices are the infant mortality rate, that is, what percentage of infants die during childbirth, the life expectancy at birth. So what can an average American, how long can an average American expect to live if they're born in 2019 or 2020 versus the average person who is born in Kenya versus France versus Cambodia versus Nigeria? What is the life expectancy, and how does that reflect larger social organization? And then overall mortality rates, that is the rate of death from disease within some given period of time. So we can look at how we stack up against other countries, how the United States stacks up against other countries on these indices. So this comes from the CIA's World Fact Book. It's based on 2016 data from selected countries. And we can see, and it's the infant mortality per 1,000 live births. And so the rate is the number of in the middle column is the number of children who die out of 1,000 live births. You can see the country with the least number of the lowest rate of infant mortality is Monaco, a small country, surrounded by France. Japan with just 2 deaths per 1,000 live births. Italy 3 and change, and then the United States at almost 6 infant deaths per 1,000. So that's nearly 3 times that of Japan, 3 times that of Monaco, twice that of Israel and Italy, but not as high as many other countries in the world. If we go down a bit farther, we can see Mexico at about 12, Haiti, which is typically known as the poorest country in the Western Hemisphere, at almost 50 deaths per 1,000, Afghanistan, a war-torn country in the Middle East, at 112. It's interesting, though, to note that the United States is a more wealthy country than Italy, than Japan, certainly than Cuba, and yet its infant mortality is quite a bit higher. And so we can ask, it raises important critical questions. Why does the United States rank 57 out of 225 countries when when the United States has at least one of the most powerful, is one of the most powerful economies in the world? And part of that may have to do with lack of access to health care. All of these countries above US on the list have some form of universal health care, and the United States has something like 9 or 10 million people who don't have health care, despite a number of different efforts to provide health care. We still have people who don't have it, or who are underinsured. That is, they have it, but they don't use it because it would likely result in costs that they can't afford. Okay, another index is life expectancy at birth. Again, we can see that the United States, while it's not at the bottom of the list globally, which makes sense because many countries are quite poor and have many struggles. It is not so far up in the list given its status as one of the wealthiest countries in the world. Again, people who are born in Monaco as of 2016 can expect a lifespan of a healthy 89 and a half years. That's the average. Japan, 85 years. This is both men and women average. We do know that women in most countries tend to live longer than men, so this is an average of all people. Hong Kong, 83 years, Sweden, 82, and the United States at almost 80 years life expectancy, which is ranked at 42nd out of 224 countries around the world. And that number has increased over the past several decades, but its rate of increase has slowed, as you might expect. I mean, the advances in life expectancy had big jumps from things like sanitation back in the 19th century and early 20th century that decreased airborne and foodborne and waterborne diseases. So there were jumps in life expectancy. And then the rate of that increase in life expectancy does tend to slow just for biological reasons. There's a sort of theoretical maximum to how long a human being can live. But in the United States, there's actually, if I'm not mistaken, there's been a downward turn in life expectancy, which is quite troubling. Sorry for that pregnant pause. If we go down the list, we can see that the life expectancy of some countries in the southern hemisphere, such as Chad, are quite low. Chad, for example, a country in Africa, there's a 30-year spread between the life expectancy of Chad and that of Japan, which is at the top of the list. And it probably reflects these broader social organization and the social systems in place. But Chad is a very poor country. There are many people who die of intestinal diseases, respiratory diseases, probably because there's not immediate access to fossil fuels for cooking. And so many people use wood-fired stoves to cook, and this is much more harmful to the respiratory system. And of course, it's burned right there at the site of cooking as opposed to, or much closer at least, as opposed to the ways that Americans who may cook their food with natural gas or electricity are able to sort of, it's less particulate in the air than wood burning stoves, and it's often chimneys take that smoke away. I mean, not like Chad doesn't have chimneys, but the sort of particulate matter is heavier from wood burning stoves and makes it down to the level of people breathing that air. So there's a lot of respiratory disease, things like malaria, and then HIV has had a pretty detrimental impact in Chad and other countries in sub-Saharan Africa where rates of HIV, which also reflects social organization, access to preventative services, access to treatments for HIV for those who do contract HIV. And so been quite a battle on the international level to get the HIV epidemic in check in other parts of the world that don't have the same kinds of medical technologies and access to resources as a place like the United States or Western Europe. So of course this is relative, but it again reflects that broader point about social organization and how it can determine things like life expectancy and who gets an illness, who gets a disease, and who doesn't, that are not just a matter of individual lifestyle choices, not just a matter of individual behaviors, but are shaped by that broader context. Just a number of other graphs to show you where the United States stacks up. If we look at mortality rates, which is mortality being the rate of death, usually in relation to a specific disease, we can see that deaths per 100,000 people in 2008 in the United States was around 500, and that is again taking into account all different diseases. This is from the World Health Organization. And, we're not doing the best if we look at other comparable countries in Western Europe and North America, such as Canada, and then in Australia, which is very similar culturally to the United States, but has much lower mortality rate than the United States. Again, raises interesting questions. Why? Why might that be? And does it have something to do with the way that our healthcare system is organized? Mortality rates from injury. United States, again, pretty lagging as compared to a bunch of other comparable countries in terms of the way that they're organized, their economic prowess, and so on. And violence. United States really much more likely to die of violence in the United States than our peer countries, according to the World Health Organization. Again, really interesting question. What accounts for levels of violence in the United States? Does this have something to do with the accessibility of certain kinds of weapons in the United States? And of course, interesting debates over how easy it should be to have access to a gun, for example. Does it have to do with something else about our culture? Do we have a culture of fear where we're more likely to think someone is going to enact violence upon us and react in a different way from other people? What is driving that? Again, raising questions here. I'm not giving you the answers, but they're really interesting and important sociological questions to ask. This next chart shows us the change in life expectancy, and I alluded to this a little bit earlier, that has occurred over the 20th century. So in the United States, you can see that in the year 1900, a person could only expect to live about 49 years. And the infant mortality was 100 deaths per 1,000 live births. By 1950, life expectancy had improved quite dramatically by almost 20 years. And the infant mortality was cut by 60 to 70%. I'm sorry, cut by about 60%. And then it has risen into the 2010s, but of course this big gap between 1900 and 1950 reflects some pretty dramatic changes in social organization during the first part of the 20th century. Well, what kinds of things? Well, I already mentioned one of them. Things like public infrastructure and sanitation measures that as our cities and urban areas began to be developed and people realized that the germ theory of disease, for example, people realized that there were ways of creating infrastructure that removed sources of waste out of proximity from our drinking water, from our food supply, and that affected the quality of the air in these urban centers in terms of what kinds of diseases might be airborne. And that had a very dramatic effect on how many people were dying from food-related and water-related illnesses. Vaccination campaigns were also extremely important in bringing the life expectancy up. Vaccination campaigns against typhoid, cholera, rabies, tetanus, and tuberculosis. Many thousands and even hundreds of thousands of people dying from some of these diseases, from outbreaks of cholera, for example. We haven't had a dramatic cholera outbreak in quite some time in this country, though they have had them in recent decades in places like Venezuela and other countries that it may have gone through economic turmoil and turmoil in terms of war and so on. And then, of course, the increasing use of antibiotics. Antibiotics being discovered earlier in the late 19th and early 20th century, but not in widespread use for all kinds of different diseases until the 1930s and 40s. Again, just being able to kill bacterial infections with antibiotics. Of course, now the problem is antibiotic resistance from overuse and from people, being prescribed antibiotics for things that don't need it, or people not taking their antibiotics for the full duration of what they're required, and just the proliferation of antibiotics in our society for everything is allowing for resistance to antibiotic resistant bacteria to spread. And really, the CDC is quite concerned about what kind of danger this is going to pose in the next decades, and how we might curtail that. I just have about 8 more slides. In case you're getting bored, you can take a little break. I hope some of this information is interesting to you. Another important advancement came in the 1960s and 70s that may account for some increase in life expectancy, and that is the passage of Medicaid and Medicare. So there was a big drop in infant mortality. You can see that here between 1950 and 2000, and a relatively substantial increase in life expectancy. And it may be no coincidence that it was in 1965 that President Johnson signed into law Medicaid, which is a healthcare, federally funded healthcare for low-income people or people with disabilities, and Medicare, a healthcare system for government healthcare for people over the age of 65. That was not available to people in those groups before 1965, and it allowed people to have pre- and postnatal care if they were poor, which probably, it most certainly had a lot to do with infant mortality coming down, the rate of infant mortality coming down, and then just having preventative services or catching an illness early. If you're an elderly person, you didn't have and couldn't afford to go to a doctor, didn't have private health care. Now that you have health care because of Medicare, you can go to a doctor on a regular basis, be screened for things like cancer and heart disease, and have access to certain kinds of medications that may decrease your risk. And so all of these things combine to improve the overall health of large groups of people in the United States. And of course, now there's a big debate on whether we should be expanding Medicare to include, say, people 55 and older instead of 65 and older, or whether we should change such that anybody can buy into health care if they want, or keep their private health insurance. And then at the most, I would say, I want to say aggressive, or most aggressive in terms of the timeline. Some people think that you should just simply have Medicare as a right of birth, that you just are automatically covered by a national health insurance that is structured through Medicare, and that if you want to buy private health insurance, you can do so on your own at your own expense. And there's a political debate happening around what's the best way to get everybody covered and to reduce the costs of a very expensive healthcare system that we have. We pay twice as much of GDP than the next most expensive country on earth. We pay 19% of our gross domestic product on healthcare costs each year, and the next most expensive country, I believe, is Switzerland, pays about 11% of gross domestic product, GDP, and also covers all of their people, whereas we don't cover all of our people. So people are asking why. Why is it that we have such an expensive medical system, healthcare system, or patchwork of healthcare in the United States? And what is preventing us from having access for everyone at a fraction of the cost that we're currently paying? It's an important debate. I'm not going to talk much about the leading causes of death. You can take a look at them here, pause the video. The risk factors as causes of death, tobacco being a leading cause, illicit drug use up there. This may need to be revised because we've seen a real increase in overdoses on opioids, accounting for something like 50 to 60,000 deaths last year, so this is an outdated figure. Although illicit is a key term here, some of those overdoses are perhaps not illicit, but prescribed uses of opioids, although it tends to be that they're not being used in the way that is prescribed, but rather people become addicted to them. And here are some of the health risk factors associated with poverty in the United States. Things like, so first, poverty is associated with poor outcomes, which is probably not shocking to you. Although some people say, oh, you're stigmatizing people who live in poverty by suggesting such an association between poverty and health outcomes. Yes, there is stigma around people who live in poverty, and certainly it's not like the point isn't to say people live in poverty because of their own choices, but and that this is what's caused them to become ill. So I'm always a little bit surprised when people are resistant to the claim that the poverty and poor health outcomes is simply a sociological fact, and we can ask questions about that relationship without necessarily blaming people who live in poverty for their bad health. The very point of saying the difference between the difference between individual lifestyle and behaviors versus fundamental social causes is to draw our attention to things that are largely out of people's control, that shape the individual choices that people have available to them in the first place. So things like unsafe working conditions, environmental toxicity in poor neighborhoods. So this is a very interesting phenomenon. If you're a poor person, you may only be able to rent or buy a home, if you can afford to buy a home, in an area that's next to and of course I'm not saying this is universal, but you're more likely to be only able to afford to buy a home close to industry, where housing prices are lower because people don't want to live next to smokestacks, or next to a waste facility. Again, because people don't want to live there, the housing tends to be cheaper, and those who only can afford so much tend to buy up those houses where there are environmental toxicity exposures, or places where there was, say, a gas station where the cleanup of the gas station wasn't sufficient, and sure, you're exposed to lead or to other contaminants in the soil. Your kids are playing in that. Maybe they're around lead or something like that because it's an old house that hasn't been retrofitted or renovated. All those kinds of factors that, again, I'm not talking about any given individual, but we're talking about group level phenomenon. Inadequate and unsafe housing leading to accidents, again, that tend to be cheaper because they're not renovated, not kept up. Diet, I've already talked about. Exposure to urban violence. Again, if you're poor, you can't just move out of the city, the part of the city that has high crime rates, because you can't afford to get an apartment in the safer part of town. And then inadequate access to health care, either because you simply don't have health care, or if you do have it, you don't go as often to a doctor for preventative services or to get treatment because even a little bit out of pocket may mean you can't pay for food that month, or you can't afford your rent that month. So this leads us to something that's really important in sociology, which is called the health-wealth gradient. The health-wealth gradient is simply the idea that there is an association between levels of wealth and health outcomes, with richer people having better health outcomes and a longer life expectancy than poorer people. And then if we look within poor people, we see that people of color are more likely to occupy a lower socioeconomic status for a number of historical reasons and sociological reasons than are white people, though of course there are certainly many white people also living in poverty. The number of people living in poverty that are Black or a racial minority is disproportionately people of color. People of color are disproportionately likely to live in poverty compared to their white counterparts. And so that's how we can talk about intersectionality, how socioeconomic status and race intersect in important ways, and that we have to sort of think of these things sometimes together, and sometimes we have to think of them separately, but in no way do we mean to diminish the struggle of any individual who may live in poverty, regardless of their race, regardless of other aspects of their background. Every person who lives in poverty is at risk of having poorer health outcomes and deserves the recognition of that. And yet sociologically, we can also ask questions like, why is it that racial minorities, ethnic minorities are more likely to not have access or not seek out access to healthcare for historical reasons? How do we explain those phenomena? So this is just a graph which shows us this interesting wealth health gradient. So if we look at the top line, this blue line, it shows, well, first of all, the figure is the percentage of people reporting poor or fair health by poverty level status during this period of time. And this is, continues to the present day. It's not much change in this graph. So if you look at these lines, they represent, here's the key, the blue line is people who make under the federal poverty limit, which is about $11,000 to $12,000 a year. So they are more likely, so about 25% of people who make under 100% of the federal poverty limit, that is about $11,000 to $12,000 a year, 25% of those people in that group report for fair or poor health, compared to less than or about 5% of people who make 400% of the federal poverty limit. That is to say, who make around the median income in the United States of $48,000 to $50,000 a year. So all this is showing is that if we go up each bracket of based on the federal poverty limit, we see that those who are poor are more likely to report poor health outcomes than those who are richer. And this makes sense. If you're poor, you don't have extra money to pay for medical health services. You may have access to things like Medicaid, but you may not use that Medicaid. You may not know that Medicaid pays for certain things, and so you may be reluctant to go to a doctor, or you may not even know that you're eligible because of the distribution of things like education around who has access to Medicaid and who doesn't. So I want to call your attention to racial and ethnic differences in health and life expectancy outcomes. I alluded to these differences a lot in my lecture, but I haven't actually shown you. So if we look at the life expectancy by race, ethnicity in the year 2013, we can see that, the first graph is of infant mortality. Infant mortality for all babies born in the US is about 6 out of 1,000 live births. Among white people, it's a little less than the average, overall average, and that's 5.1. For black people, black babies, it's twice that of white babies, 10.8 deaths per 1,000. And note that Hispanic or Latinx people, Latina and Latino people, 5, about the same as white folks. And then American Indian in between white and black at around 7.6. And Asian and Pacific Islander people, again, a large group of people lumped together, not really recognizing the differences between these folks. This is how the data are collected, about 4 deaths per 1,000. And so we see disparity primarily between white and black people in this country. And this disparity reflects access to certain kinds of resources. And, based on some of the factors that I have already discussed. And then that is of poverty. If you have a greater percentage of black folks, African American folks living in poverty, and again, I'm not saying that all black people live in poverty, I'm just saying that proportionate to what you would expect, and the overall percentage of black people in the United States, they are, as a group, disproportionately likely compared to their white counterparts to live in poverty, which may reflect the legacy of racism in our country, of lack of opportunities, of certain economic policies, of policies which prevented black people from moving into certain neighborhoods, from climbing the economic ladder. In some part, there is a history of racism within the medical establishment. Again, not saying that people who work in the medical establishment are racist, but that there is a legacy of not respecting the autonomy of black people in medical experiments up into the 1970s at least, and sort of the legacy of that built into these systems, which may discourage some black folks from reaching out to medical authorities or feeling that they can trust doctors in the way that white folks may feel more comfortable going to the doctor more frequently, and those with just even a small increase in the average of visits to a doctor may help to explain why health outcomes are better among white people and for something like childbirth. And then if we look at life expectancy, we see the same patterns, a very large divide between white and black folks in the year 1900, with white people living on average about 14 to 15 years longer than black folks. Again, perhaps not surprising in 1900, and we can see that this gap has closed somewhat, and yet there is still a significant statistical difference in life expectancy between white and black people in the United States as of 2014, and I can tell you that this overall difference is still apparent. So how do we explain that? What are some of the reasons for this difference in life expectancy? Well, one, and this is well documented in the sociological literature, black people die more frequently from heart disease and cancer than white people. If black people are more likely to get coronary heart disease as a product of, or as a function of, socioeconomic conditions and stressors, and are less likely to have access to health care and services to treat heart disease and cancer, then they are more likely to die early from it. Particularly important factor in explaining this difference is racial segregation. Racial segregation is the greatest for black people of all minority groups, except indigenous people who disproportionately live on reservations. And so this is true for black people even as they have climbed the economic ladder over the, let's say, latter half of the 20th century and into the 21st. They still live in relatively segregated communities, and those communities lack the same kinds of opportunities and resources as their white counterparts. This means that more black people remain exposed to social stressors of poverty, even when they may be in the middle or upper class. So that's really important. So if racial segregation at the neighborhood level continues to exist, despite the fact that black people have made economic gains, then they may live in a neighborhood that doesn't reflect their current socioeconomic status. That is, you have middle class and upper middle class black people living in neighborhoods that tend to be still those affected by poverty, and that have the kinds of challenges that impoverished neighborhoods have, like exposure to violence, like lack of a variety of food choices and things like that. So the ongoing legacy of segregation that has been a product of racism and racial discrimination at the individual level, but also as a product of housing discrimination, of not giving Black people loans even when they have good credit to qualify for them to buy their home in the place of their choice, has these material impacts, and these material impacts have consequences for people's health. If we look at gender differences, we also see an important trend. So first, the overall trend that women tend to live longer than men, regardless of race, and that when we look at gender by race interaction, we can see that Black men have the shortest life expectancy of these four groups. So we have white men not living long as white women, Black men not living long as Black women, but what's interesting here is that well, we can ask, for example, why don't men live as long as women? Is it something about just biology of gender? And you'll, of course, recognize that transgender people are not in this chart, and their life expectancy may be lower overall than any of these groups, although I don't know that we have good systematic data, but we have some reason to believe that health outcomes for transgender people may not be as good, reflecting a number of socioeconomic differences as well. And of course, it may matter if you're a trans woman versus a trans man. But so between men and women, men are exposed to greater occupational risks than are women due to their expectations on men and what kinds of occupations they're expected to hold. And they also tend to smoke more, which might be a product of the stresses of certain kinds of jobs, though certainly there are women who have stresses in their jobs as well. I'm talking about average differences. And so, white men have occupational safety threats from working in, more likely to work in laboratories or hard labor conditions. Men are still disproportionately likely to go to war and to be exposed to physical violence, though of course disproportionately sexual violence is enacted upon women, but also upon men, but just disproportionately toward women. But so these trends are explained in part by occupational differences. Women are also, there's a different phenomenon here that can explain. Women are more likely to reach out for social support when they do have an illness and to go to a doctor to get help. Men might be something about masculinity and kind of like, oh, I should be able to take care of this myself. I don't need someone else to help me. This reluctance to seek out help may explain the fact that men, when they do finally get to a doctor, are often more sick than their female counterparts. So that is, women who have cancer or heart disease or something, they tend to catch it early, tend to get treatment, and therefore resolve the problem, and they're able to live longer, whereas men wait too long to go to the doctor. By the time they get to the doctor, it's too late. So that can help explain these gender differences as well. So if we look at the gender by race interaction, we can see that white women live the longest at 81 years, black men live the shortest, and white men and black women living about the same, having about the same life expectancy. So if you look more closely, you can see that whatever advantage women have as a whole, it's largely erased for black women. Again, let me say that whatever advantage women on average, if we're just thinking about women versus men, that women live longer than men, that's erased if you're a black woman. And so again, why? Why is that? Well, it may have to do with the stresses that come with racial discrimination. If you're a black man, it may have to do with the fact that incarceration rates are so much higher among black men than they are white men, and in a large part reflect social conditions and laws and procedures that end up targeting black men, or yielding longer sentences on average, well documented in the sociological literature, longer sentences for the same crime if you're a black man compared to a white man. And so these larger sociological phenomenon help to explain some of these disparities. So just in closing, I know this was a very long lecture. I hope that there were some little tidbits of information, or at least some questions that you come away with that pique your interest, that you might want to look into a little bit further. And I just wanted to show you that inequality, social inequality, and economic inequality have a very important impact on health disparities in the United States and across the world, and that we have to ask very important, nuanced questions to really understand these larger trends that we're able to identify by using statistical analysis, looking at group level differences, and using our sociological imagination to attend to what is not visible to us just in our day-to-day lives, or may not be visible to us, that is revealed by studying systematically the data that we have, that we collect at a larger level. So with that, I will end. Wish you a very good week, your last paper. And if you do have questions about this or want to chat about anything, please note it on the discussion board or send me an email. All right. Bye, everyone.